Hi, and welcome to 11th edition Pre-Hospital Emergency Care. This is going to be Chapter 1, and we're going to get started here going over emergency medical care systems, research, and public health. Take your time to go through the next few slides to look at the objectives for this lesson, as well as the case study and the questions referring to the case study. And we'll get started here at the introduction. Again, welcome as we get started with Chapter 1. So today we're going to be talking about EMS systems in general. And one of the most important critical health problems in the United States today is the sudden loss of life and disability from catastrophic accidents and illness. And as your book refers to it, it is a major public health problem, meaning that this is something that is affecting the public and it can be fixed. Now, thousands of people die every year because of lack of adequate access to EMS. If we can get care to those patients sooner, if we can get more access to our patients, there's a better chance of survival for all of our patients. Now, I'm sure you guys are familiar with EMS or the emergency medical services, and maybe even an ambulance. Maybe you've rode along on an ambulance, or you know what it's like to be an EMT. Maybe you've even seen on the movies or on TV shows what it's like to work in the pre-hospital care environment. Well, that wasn't always the case. It used to be that ambulances were started from funeral homes and they wouldn't deliver care until the patient actually got to the hospital. So the ambulances would go pick the patient up, transport them to the hospital, and that's when care started. But as we've learned, it's actually better to get care to our patients sooner. Though a lot of the things we've learned from this are actually from wars. The Korean War and the Vietnam War showed us that it's better to have those mobile hospital units. And if you've ever seen the TV show MASH, you'd probably be somewhat familiar with that. Now, it's interesting because the Korean and Vietnam Wars weren't the first wars to bring the hospital to the front lines. The first war was actually or the whole idea actually started from Napoleon. Napoleon was the first one to have an idea that what if we brought the hospital closer to the front lines? Would we be able to save more of our soldiers and more of our patients? And it's true. And that's how we've really evolved and a lot of what we've learned from. And that's how our EMS system has actually grown, is by getting care to those patients sooner. Now, we still learn a lot from wars. The Iraq War, the Afghanistan War, we have developed a lot of the trauma care that you're going to be learning in this class from those wars and from those military trainings and skills that they have learned and they've passed along to us. It's important to understand that EMS system today is a part of a continuum of care. It is not that pre-hospital care is the most important or the best. It's that we are just one small aspect of the whole healthcare system. We're kind of like the tip of the spear is how I like to think about it. We might be the first person to access the patient after their traumatic accident or maybe during their heart attack. We'll be the first ones to see them. Now, we're going to start the care process. We're going to start the patient assessment and the treatment of this patient. But this patient's journey through the healthcare system is going to take much longer than just the small portion of time that we're going to be with patients. As EMTs or paramedics, we're only with patients sometimes for 10, 20, maybe an hour or 2 hours, depending on how close your hospitals are. So we're not with our patients for too long of periods of time. Now, you have to think this patient's going to go to the emergency department where maybe they're going to go into surgery or get admitted to the hospital. And then they're going to have to go through rehabilitation. And this patient's injury or illness is going to be a lot longer than the small aspect that we spend with patients as EMTs. As you can see in front of you, we have a small timeline of a little bit of the history of EMS. Now you can see that actually CPR was not really even started till the 60s, but that was even before we were around. Really, EMS got its start at the date of 1966, and it's important that you guys remember this. In 1966, EMS came out with what we call the White Paper, and the White Paper specifically was titled The Accidental Death and Disability, the Neglect, the Neglected Disease of Modern Society. It was published by the National Academy of Sciences National Research Council. That's a long name, but that is what kickstarted EMS as we know it today. The idea was that we have a modern problem. We have a neglected disease, and that is the people who are dying or becoming disabled due to accidents, whether that's injuries or illnesses at home. And that is what gave EMS its start right there, the White Paper. And it's important that you guys remember that. Now, also in 1966, we have the Highway Safety Act that really helped kickstart our EMS systems as well. And this is actually an act developed by the National Highway Traffic and Safety Administration, and that is a subset of the DOT, or Department of Transportation. But what the Highway Safety Act of 1966 said was that each state is responsible for developing its own highway safety program, or in other words, their own EMS program. And so that was another thing that happened. So in 1966, the White Paper started, and then the Highway Safety Act began the EMS systems as we know them today. Now in 1973, the EMS System Act passed, where we got a lot of funding to help us develop trainings and help us develop EMS systems at large. And it was really just a thing to help push off and give us more finances to get EMS running. And then lastly, National Emergency Medical Services Education and Practice Blueprint in 1993 was something that helped us develop a national curricula and part of the curriculum that you guys are learning in this class today. So those are some small features of some of the history of EMS. Following along, again, you can find this information on page 3 of your textbook, but 1996, we also saw this EMS Agenda for the Future. Now, the EMS Agenda for the Future was a document which was responsible for helping make EMS a greater component in the healthcare system. We also followed that up with an agenda for the future, a systems approach, again, helping to address different issues related to consistency of education or training or other licensure levels. Now, 2005 and 2006 are really important. 2006, the National EMS Scope of Practice model is what actually defines the 4 different levels of EMS licensure. Now, I'm sure you guys have heard of these, and these will be coming up in this chapter, but EMT, paramedic, those are different levels in our EMS Scope of Practice. We actually have 4 different levels that we're going to be learning about later on. All right. As we learned back in 1966, the National Highway Traffic and Safety Administration was responsible for telling each state that they are responsible for developing their own emergency medical services system or program. And so still today that remains true, that each state is responsible for planning and coordinating their own emergency medical service system. And then there's an agency actually in charge of all of the EMS systems. You can actually go online to emsa.ca.gov and find our California Emergency Medical Services Authority, and that is the agency that is responsible and over our state of California. All right, like we learned, right, the National Highway Traffic Safety Administration said that each state was responsible for developing their own emergency medical system or services. All right, now they also said that every EMS system must have these 10 things, and these 10 things are regulation and policy, resource management, human resources and training, transportation, facilities, communications, public information and education, medical direction, trauma systems, and evaluation. You can find more information on each of these 10 components of the EMS system in page 3 of your textbook. I don't know how many of you guys have ever had the opportunity of calling 911 before. It's not something that you want to have to do, but you're always happy that they're there. Now, 911 is the US's emergency phone number, right? This is who we call, and we're able to access different emergency services, whether that's police, fire, or EMS. right? And we can reach all of them through just this one number. That's super helpful. And then they can divert the appropriate resources to our scene or to our emergency. If you have a burglar in your house breaking in with a gun, you do not want me on an ambulance to come help you. You want a police officer. But either way, you don't have to remember one number for the ambulance service and one number for the police department. We can just remember that one number. Now, we also have another thing, and this is enhanced 911. And be careful because in your book, we have actually two different phases. We have basic 911, which is just calling 911. We have enhanced 911 phase 1, which provides us with automatic number identification and automatic location information. So if someone calls 911, this is what we have in place in most places today. You are able to get an automatic callback number as well as the location that the patient is calling from. Now, this is super helpful. If we were ever to become disconnected, we could still send emergency services out to your location, and we could still try to recontact you by recalling that number. All right, so I don't know how many of you guys have ever seen one of these before, but this is a dispatch center, also known in your book as a PSAP, or a public service answering point. I would not want to be here. You can see all these different TV screens and all these different things. Multitasking would definitely be very important. But one thing that's important for you to remember as an EMT is that sometimes the people behind the phone, the dispatcher, is emergency medically trained. So some of them do have trainings, and they're known as emergency medical dispatchers. And they're able to give advice and help with treatment over the phone before you get there as an EMT. So you guys all have cell phones, and we've used cell phones for years, and some of you guys have probably used them your entire life. But cell phones have posed a huge problem for 911. If you call 911 on a cell phone, how are they supposed to identify your location, right? As we know with the enhanced 911, with the issues of a cell phone. Now, the way that this is taken into effect is through phase 2 of enhanced 911. And this actually requires all wireless service providers that they must provide the latitude and longitude of the caller. And they're able to get within 50 meters, right, of the person calling. It is very accurate. And so we can still identify somebody's location with a cell phone. It just makes it much more difficult. Now, the FCC, or the Federal Communications Commission, is what's in charge of making sure that everybody has access to 911. Remember, we want all of our patients or all people to have access to 911 because they're going to need it at some point in their lives. Now, the next slide covers voice over internet protocol, which is something else that's posed threats to getting into contact with 911. Voice over internet protocol might be Facebook Messenger, Line, or Viber, or other things that you call using Wi-Fi, maybe like FaceTime, instead of maybe using your cell phone or a landline. Now, voice over internet protocol, FCC has imposed requirements for those as well. Number one is it must be a standard feature for every customer. Also, that person is going to now need to give a physical location as well as some sort of a callback number that they can be reached at. But these are two hurdles that have been an issue for getting into contact with 911, and we can see how we're trying to handle those today. So you guys might not be familiar, but there's actually different types of EMS systems. And there's actually different types of EMS systems all over the country, and we don't all use the same system. As you can see, we have different fire department EMS systems, municipal EMS systems, private EMS, hospital-based EMS, and even law enforcement EMS. And so there's different types all over the country. Now, a fire department EMS system would be one where you have the fire department and they also provide emergency medical care, like most of our fire departments in California. You know that paramedics and EMTs work for fire departments. And some of those fire departments actually have their own ambulances and transport their own patients. A municipal EMS system would be a city-run or city-governed EMS, sometimes also called a third-party EMS system. Third party being you have fire department, police, and now your third party EMS. And then private EMS. This is what we have in Riverside County. So we have a private company, and in Riverside County at the moment, it's American Medical Response, or AMR. Now, the fire department responds to the call, right? And they have their EMTs and paramedics. And the ambulance, the private EMS system, also responds to the call. So in Riverside County, we have two fire department EMS as well as private EMS. And the private EMS is responsible for treating and transporting the patient, right? Whereas the fire department EMS is responsible for treating but not transporting that patient. So we have four different levels of providers. Remember, this was defined in 2006 by our National EMS Scope of Practice model. Now, our four different levels of providers are number one, your emergency medical responder, also called first responder. The next level above that is emergency medical care technician, also known as the EMT basic. Above that, we have the advanced emergency medical technician, or AEMT, and then at the highest level, we have the paramedic. Now, in California, you might not see all levels of providers. It just kind of depends on where you work. In California, we use a lot of the EMTs and paramedics and not so much of that advanced EMT level. Other parts of the country, that's not true. They use more of the levels of responders. It just depends on your EMS system, where you are and where you work. And you'll need to get familiar with that as you start working in the field. Because the United States is a very large country and we have a lot of different states and so many different types of EMS systems, all right, we tend to use different words for different things. Well, in this slide, we see that problem. We have pre-hospital care and out of hospital care. And really, guys, I want you guys to just know that these two words are completely the same. When we say pre-hospital care, we're referring to the care that EMTs and paramedics give. But however, you have to be aware that that is not always pre-hospital, right? The care that we give as an EMT is not always going to be before the hospital. Sometimes we transfer a patient from one hospital to another, and in that situation, right, we're still giving care. So that's why we use these different terms. Some people say, well, it's not technically pre-hospital, so we'll just call it out-of-hospital care. Other people just like to pre-hospital care. Be familiar with what's used in your area, but either way, you guys, the terms mean the same thing. All right, so what are some responsibilities that all EMTs share? Click through the next couple slides to find out what some of those things might be. What are some personal attributes that are important for all EMTs to have? You can click on the next slide to see a list of some of the important personal attributes, as well as to look through your textbook, pages 9 through 11, to see other important ones listed in your textbook. Medical oversight of EMS. Now, every EMS system is responsible for having a physician medical director. This is a physician who is actually in charge of the EMS system. And as an EMT, you're actually a designated agent or maybe even an extension of that physician's authority. You're working under this physician's authority as an EMT. Now, they have two responsibilities. They have indirect medical oversight, which are not fun things. This is the paperwork and the other policies that they have to sort through on their own time. The direct medical oversight directly applies to you as an EMT. The way this works is through on and offline medical direction orders. There are some situations where we need to contact our medical director or contact a physician and get an order, maybe for a specific medication or a specific treatment. That's considered an online order because we're having to use our phone line or cell phone or radio to contact medical direction. There are some orders that are considered offline, where they allow us to do things and they are written down in our protocols or procedures. And so those are referred to sometimes as standing orders, where I know I don't have to contact my physician in order to administer oxygen to a patient. But maybe for another medication, maybe such as assisting a patient with their nitroglycerin, I would actually have to contact that physician to get an order for that specific medication. Quality improvement, also called QI and sometimes referred to as CQI or continuous quality improvement, is a system of internal and external reviews and audits. Right? In other words, it helps us to make sure that the public is receiving the highest quality of pre-hospital care. They're making sure that the best EMTs and the best treatment is getting sent out to the public. All right. So the goal of CQI or QI is to identify those aspects of the system that can be improved on and implement plans and programs that will help fix those and help improve our EMS system as a whole. Go ahead and take a look through the next two slides. These two slides have high risk factors in patient safety or a list of different things that might be dangerous to our patients. You can take a look through these two things and see how we might need to use quality improvement to make sure that we don't have issues in patient safety. The next couple slides are going to be dealing with evidence-based medicine. Now, evidence-based medicine helps us find out what medicine is best for our patient. And I love this definition. It uses research to provide evidence that certain procedures, medications, and equipment improve our patient's outcome. Now, I was actually told by another EMS provider once that said, we need to use evidence-based medicine, not emotional-based medicine, right? Our treatment should be based off of real hard-hitting science and fact that says, hey, this is better for my patient, not what your emotions are saying at one time or another. Because when we're in a dangerous call or a stressful call, our emotions should not dictate the care that we give our patients. EMS and public health. I wonder if you've ever heard the saying, preventative medicine is the best medicine. As an EMT, you might find yourself as having to be in a role of helping to protect or prevent medical problems before they ever happen. Now, public health attempts to reduce the incidence of injury and illness through preventative strategies geared at protecting and promoting and improving the health of a population. As an EMT, you might be responsible for teaching CPR classes to a layperson, or even maybe responsible for helping at a health fair check blood pressures. There's a lot of different ways that EMTs can find themselves doing this. Click through the next couple slides to find the 10 greatest public health achievements, as well as different ways that EMTs find themselves in public health roles. A new topic in today's EMS system is mobile integrated healthcare or community paramedicine. These are not the same terms, and we'll define them a little bit in just a second. However, go ahead and read through the next two slides. You're going to read a story about a guy named Buddy here in a local California town, and we're going to talk more about how mobile integrated healthcare and community paramedicine might benefit your patients. Mobile integrated healthcare and community paramedicine are not the same terms, but these are new topics to EMS. Mobile integrated healthcare is actually going to integrate other healthcare professions. Maybe that's a nurse practitioner or even an RN into the EMS system, sometimes even using doctors. Community paramedicine is an advanced level certification for a paramedic that might help, right, an EMS agency deliver different or alternative care to patients. As you saw a few slides ago with the story of Buddy, the EMS services have really failed him in providing appropriate or proper care to help fix his problem. Community paramedicine or mobile integrated healthcare is a way that we can help fix that. Maybe this is something that we don't have to send a patient to an emergency room. Maybe we can send them to a specialty center. Or maybe we can manage chronic diseases over time, right? Instead of taking every single patient who calls 911 to the hospital. Now, this isn't in place in every part of the country yet. However, we do see some EMS systems who are using both mobile integrated healthcare or community paramedicine.